Welcome back to the deep dive. Today, we're tackling a really core topic in modern medicine, informed consent.
That's right.
It's foundational, ethically and legally, for how doctors and patients interact. But, it's so much more complicated than just signing a form.
Absolutely. It's critical stuff, whether you're, prepping for a class, studying bioethics, or honestly just trying to navigate the healthcare system yourself.
Definitely.
We're going to trace how this ethical idea, really rooted in autonomy, became this binding legal requirement.
Yeah.
And also why it sometimes struggles, in practice to live up to its moral promise.
Okay, so let's start with that ideal. What is informed consent at its heart?
Well, simply put, it's the action of an autonomous person, someone who's informed, agreeing to medical treatment or maybe experimentation.
And the justification for it, ethically speaking, it's not just one thing, is it?
No, it's really a powerful mix. First, and maybe most importantly, is autonomy. It's about respecting a person's capacity to make their own decisions, self-determination. It pushes back hard against that old-style medical paternalism where the doctor just decides for you.
Your body, your choice, essentially.
Exactly. And the second pillar is beneficence.
Promoting well-being.
Precisely. The thinking is that when patients make choices that are informed and autonomous, those choices are actually more likely to advance their own best interests.
Okay, how so?
Well, they can weigh risks they find unacceptable, maybe avoid them, and crucially, they're often more likely to stick with a treatment plan they actively chose, right? So it helps with compliance, too.
So IC isn't just protection from the doctor, it's also about empowering the patient for themselves.
That's a great way to put it. It empowers better choices.
It's a real intersection of personal freedom and, well, medical reality. But you mentioned it's surprisingly young as a formal concept.
Oh, yeah. For most of medical history, patient self-determination, full disclosure, largely ignored. The power dynamic was just different.
So when did things start to shift legally?
The first big moment, legally speaking, was probably 1914. A case called Schloendorff v. Society of New York Hospital.
Okay.
That ruling gave us the foundational idea. Every human being of adult years and sound mind has a right to determine what shall be done with his own body. Big statement.
Huge for autonomy. But that was just about simple consent, right? Just getting a yes?
Exactly. Just permission. The information part, the informed part of informed consent, that came later.
When did that term actually appear?
Not until 1957, believe it or not. In a California case, Salgo v. Leland, Stanford Junior University Board of Trustees. That's where the term informed consent was first coined.
And that case linked the two, consent and information.
Yes, it established that the physician had a duty to disclose the facts necessary for the patient to give intelligent consent. And by the 60s, things firmed up more.
What kind of things needed disclosure then?
Well, the basics were laid down. The decision had to be voluntary. The doctor needed to disclose the illness, the proposed treatment, the risks and benefits, and crucially, the alternatives, including doing nothing.
Okay, that sounds more like what we expect today. But then came the tricky part. How much information is enough? Who decides that? Initially, it was the doctors themselves.
It was, yeah. For a while, the dominant standard was the physician-based standard. Basically, disclosure was adequate if it matched what other doctors in that field typically disclosed.
That sounds a bit like the fox guarding the hen house, doesn't it? Letting the profession set its own disclosure rules.
Well, that's exactly the criticism. It seemed to protect the professional more than the patient's right to know. And that tension led directly to the really big turning point.
Rose.
1972, a case you absolutely need to know. Canterbury v. Spence, U.S. Court of Appeals.
Okay, Canterbury v. Spence, what happened?
It involved a patient, Jerry Canterbury, who had spinal surgery. There was a known, though maybe small, risk of paralysis associated with the procedure.
And they didn't tell him.
They didn't disclose that specific risk. And tragically, he ended up paralyzed after a fall post-surgery.
Wow. And the court's ruling?
It completely flipped the script on disclosure. Canterbury established what we now call the patient-based standard.
Okay, patient-based. What does that mean in practice?
It means the amount of disclosure isn't judged by what doctors usually do, but by what the patient needs to make a decision. Specifically, information that is material to the decision of a hypothetical, reasonable person in the patient's position.
Material to the decision, so information that could reasonably affect their choice.
Exactly. It shifted the focus from medical custom to the patient's decision-making process. What would a reasonable person want or need to know to make up their mind?
But hang on, a hypothetically reasonable person? That sounds potentially vague. Doesn't that make it really hard for doctors? How do you know what every single patient or this reasonable person considers material?
That is the challenge, absolutely. It introduces ambiguity, no doubt, but the legal intent was to force more transparency, to make doctors think about what's relevant to the patient's life and values, not just the medical stats.
Okay, so that's the legal standard shaped by Canterbury. Now let's break down the actual components.
Hmm.
For consent to be truly informed, what conditions have to be met?
There are 5 key conditions generally recognized. The patient must be 1, competent to decide.
Okay.
2, they have to receive adequate disclosure based on that patient standard we just talked about.
Right.
3, they need to understand the information given. Disclosure isn't enough if it's not understood.
It makes sense.
4, the decision has to be voluntary, free from coercion or undue influence. And finally, 5, the patient actually consents to the treatment.
Got it. 5 conditions. Let's unpack the first one. Competence. This seems like it could get tricky, especially with, say, minors or people with mental health issues. We also hear about decision-making capacity. Are they the same thing?
Good question. They're related but distinct.
Yeah.
Competence is often seen as a more general, sometimes legal status. Are you generally considered capable of making decisions? Most adults are presumed competent. Decision-making capacity, though, is more specific. It relates to the ability to make a particular medical decision at a particular time. Someone who might be legally competent overall, but temporarily lack capacity for a complex choice due to, say, extreme pain, confusion, or severe emotional distress.
So capacity is task-specific.
Exactly. And assessing that capacity involves looking at specific abilities. Can the patient communicate a choice? Can they understand the relevant information and appreciate the consequences, the risks, benefits, alternatives? And can they use reasoning to reach a decision?
That brings up that case study you mentioned, the one about the adolescent, a 14-year-old kid.
Yeah, the case involves a 14-year-old, normally a high achiever, who's brought in acting strangely after secretly taking cough medicine, dextromethorphan. His mom is there, she's panicked, thinks it might be West Nile virus, and she's demanding a spinal tap.
Which is a pretty invasive and painful procedure.
Very. But the kid, if he's lucid enough, knows what he took. He tells the doctor, look, I just took DXM, I don't need a spinal tap. Possibly because he wants to hide the drug use from his mom or just avoid the pain.
So the dilemma is, whose decision counts? The panicked parent demanding the test, or the teenager who seems to understand the immediate situation and wants to avoid an unnecessary, painful procedure?
Precisely. Does this 14-year-old have the specific decision-making capacity in this moment? Could he be considered a mature minor for this particular decision, overriding his mother's wishes? The doctor has to assess his understanding and reasoning right then and there.
That's a tough call for the physician. Okay, moving to the second condition, adequate disclosure. You said it's based on the patient standard. What specific info does that usually include?
Generally, courts and laws require 4 main things. First, the nature of the procedure, what are they actually proposing to do?
Okay.
Second, the risks, both how serious they could be and how likely they are to happen. Third, the alternatives, and that always includes the option of no treatment at all.
Right, doing nothing is a choice.
Absolutely. And fourth, the expected benefits, what good is likely to come from it, and how likely is that good outcome.
Nature, risks, alternatives, benefits. Got it. But are there situations where a doctor doesn't have to get informed consent? Exceptions to the rule?
Yes, there are generally 4 recognized exceptions. The most obvious is an emergency. If delaying treatment to get consent would cause serious harm or death, doctors can proceed.
Makes sense. Life-saving necessity.
Second is incompetence. If a patient is formally judged incompetent or clearly lacks decision-making capacity, then decisions fall to a designated surrogate, like a family member or legal guardian.
Okay, what else?
Third is waiver. A competent patient can actually choose to waive their right to be informed. They can say, doctor, you decide, or I don't want to know the details. It has to be an autonomous choice not to choose.
Interesting. So you can consent to not being fully informed. And the last one, you mentioned it's controversial.
Ah, yes, the fourth one, therapeutic privilege. This is the tricky one.
Why is that?
Because it allows a physician to intentionally withhold relevant information from a patient if the physician genuinely believes that disclosing the information would likely cause serious harm to the patient.
Harm? Like what kind of harm?
Like making them so anxious or depressed they couldn't make a rational decision, or that the distress itself would worsen their physical condition.
I can see why that's controversial. Critics must worry it's a loophole back to paternalism, right? The doctor deciding what the patient should know for their own good.
Exactly. That's the fear. that it could be misused just because the doctor thinks the patient might refuse a treatment they recommend. So the courts are generally very cautious about it. It's supposed to be about preventing direct, significant harm from the information itself, not just avoiding a refusal.
Okay, so we've got the legal framework, the conditions, the exceptions. Now, how do different ethical theories view all this? Does, say, utilitarianism support informed consent?
Well, it depends. An act utilitarian, looking at each situation individually, might say sometimes ignoring IC could lead to the best overall outcome in that specific case.
If, say, forcing a treatment saves a life despite the lack of consent.
Potentially, yes, if the calculation works out that way. But a rule utilitarian would likely strongly support a general rule requiring informed consent,
Why?
because having that rule in place generally leads to better consequences overall. More trust in medicine, better patient compliance, less anxiety, smoother functioning of the healthcare system, even if it occasionally leads to a suboptimal outcome in one specific instance.
Hmm.
The rule produces more good overall.
Okay, what about stricter theories like Kantian ethics?
For Kant, informed consent isn't just a good rule, it's an absolute moral requirement, period.
Why? Absolute.
Because Kant insists we must always treat people as ends in themselves, never merely as means. Manipulating someone, deceiving them, or coercing them violates their autonomy and treats them instrumentally. So withholding information is fundamentally wrong. Therapeutic privilege, generally a no-go for a strict Kantian.
Treats people like objects, not persons.
Essentially, yes. And Rawls' contract theory, focusing on justice and equal liberties.
Where does that land?
It also strongly supports IC. In a just society, designed from behind a veil of ignorance, we'd all agree to principles ensuring basic liberties, including the liberty to control what happens to our own bodies. Coercion or manipulation violates that basic structure of equal liberty.
So, strong philosophical backing. But then there's the gap between these ideals and what actually happens. You mentioned theorists, Faden and Beauchamp drew a distinction.
Yes, a really important one. They talk about two different senses of consent. Sense one is the ethical ideal, autonomous authorization.
Okay, what does that involve?
It means the patient doesn't just say yes. They act with substantial understanding. They're substantially free from controlling influences like coercion or manipulation, and they intentionally authorize the doctor to proceed. It's about the patient actively taking moral ownership of the decision.
That sounds like the goal. What's sense two?
Sense two is effective consent. This is more about the procedures, the legal or institutional requirements. Did the patient sign the form? Was there a witness? Did the hospital follow its policy?
So sense two is about ticking the boxes, meeting the rules.
Right. And the critical point Faden and Beauchamp make is that you can have effective consent, sense two, the form is signed, the rules are followed, without having genuine autonomous authorization, sense one. The legal process might not guarantee real understanding or voluntariness.
The paperwork doesn't always equal true consent.
Precisely. And that gap is illustrated really starkly in that other case study, the one about Jane Doe and the kidney transplant.
Right, tell us about that. What happened there?
Jane Doe needed a kidney transplant. She got one. But she wasn't told something pretty significant about the donor.
Which was?
The donor was a 38-year-old gay man. Now, according to CDC guidelines at that time, this classified the donor as high risk for potentially transmitting certain infections, even if tests were negative. The transplant team knew this. The organ procurement organization knew this.
Well, they didn't tell Jane Doe.
They did not disclose the donor's high-risk status to her.
So they might have followed some procedures, maybe got a signature sense to effective consent, but they withheld information crucial for her to make an autonomous decision. That sounds like a failure of sense one.
Exactly. It's arguably a failure of both. But withholding material information relevant to risk assessment, they likely failed the patient-based standard for disclosure, a sense two failure. And more fundamentally, they absolutely deprived her of the ability to autonomously weigh that risk and decide if she wanted that specific kidney, a sense one failure.
That really highlights the problem, which maybe leads to why the critic J. Katz called informed consent a fairy tale or myth.
Yeah, Katz was quite critical. He argued that despite the legal doctrine, the actual practice often falls short. He felt that medicine is still deeply rooted in paternalism, and doctors often struggle with or are uncomfortable sharing the inherent uncertainties in medicine.
So they fall back on just listing risks, treating it like a legal shield.
He suggested they often treat it as a legalistic duty to warn, kind of a charade to protect themselves, rather than a genuine dialogue aimed at shared decision-making.
Okay, if the ideal, sense one, is hard to achieve, And the legal standard, Canterbury, can feel bureaucratic, sense too. Is there a more practical approach, especially for busy doctors, say, in primary care?
Well, Howard Brody proposed something called the transparency standard as a sort of practical middle ground.
Transparency standard, how does that work?
Instead of trying to list every single possible risk from a legal form, Brody suggests that disclosure is adequate when the physician's basic thinking about the recommendation has been made transparent to the patient.
Basic thinking, like their reasoning.
Exactly. The doctor should explain why they are recommending this treatment over others, what the main considerations were, what alternatives they thought about, what major risks they weighed, the rationale behind the choice.
So it shifts the focus from a comprehensive list of risks to a conversation about the doctor's thought process.
Precisely. The idea is to make the physician's reasoning clear enough that the patient understands the basis for the recommendation and can then ask meaningful questions until they feel they have enough information to decide. It tries to integrate consent into good clinical communication, not make it a separate legal hurdle.
That sounds more like a genuine conversation. Okay, so let's try to wrap this up. Key takeaways for you listening.
Yeah.
Informed consent is fundamentally about autonomy.
Mm-hmm.
Legally, the standard for adequate disclosure in the U.S. is largely defined by the patient-based standard from Canterbury v. Spence, focusing on information material to a reasonable patient.
Right.
For consent to be valid, you need those 5 conditions: competence, adequate disclosure, understanding, voluntariness, and the consent itself.
Crucial components.
And there's this persistent tension, isn't there, between just meeting the legal requirements, getting that signature, sense 2, and achieving true autonomous authorization by the patient, sense 1.
That really is the heart of the ongoing struggle. You could say the central challenge in bioethics today is still trying to overcome that legacy of medical paternalism. It's about fostering real dialogue, respecting patient choices, even, and this is hard, even when those choices go against what the doctor might think is best medically.
Which brings up a final, maybe provocative thought.
Yeah.
If doctors themselves sometimes struggle to fully acknowledge the uncertainties inherent in medicines, the fact that outcomes are never 100% guaranteed, how can they effectively communicate that uncertainty to patients?
That's a huge question. Because sharing that uncertainty, acknowledging the limits of medical knowledge, is actually essential for truly informed consent.
Right.
At the end of the day, the system relies on you, the patient, taking on the significant responsibility of weighing those known risks, those unknown possibilities, against your own life, your own values. No one else can ultimately define your best interest when facing that uncertainty. That's the core of your autonomy.
A powerful and sobering thought to end on. Thank you for unpacking all of that with us. It's complex, but so important.
My pleasure. It was a great discussion.
We'll talk to you next time on The Deep Dive.